Welcome to the Oral Apothecary Podcast, authentic chat about medicines, pharmacy and healthcare in the UK.
Pharmacists Jamie, Gimmo and STC take on topical and controversial stories but keep it edgy yet light-hearted.
Pod guests share their desert island drugs and joyful patient stories.
Welcome to the Oral Apothecary Podcast. My name is Jamie Hayes. Coming up in today's episode, we're joined by Dr. Sally Lewis. Sally is a general practitioner and national clinical lead for Valuebased and Prudent healthcare. We will welcome Sally in a moment as she shares her desert island drug, her career anthem, and recommends a book for the Oral Apothecary Library. Our micro-discussion this episode will look at the role that feedback might play in informing clinicians of patients' outcomes. Now there's a thing. Just to remind you that healthcare is a socio-techno-complex system. You're welcome. Once again, thank you for all your support and interaction and for all of your 5-star reviews. Let me welcome my two fellow apothecaries. STC is in Bournemouth and Gimmo is in Cardiff. Welcome both. What have you been up to?
Evening.
Evening.
We had some 5-star reviews, have we? I'll have to check those out. No, since
I just heard other podcasts say that, so I thought I'd repeat it.
No,
Yeah,
they
enough.
say if you give us a 5-star review, we'll read out what you said. That's
We're
what
not
they
so
say.
keen on the 4.8.
Well, that's it. We only get 4.8 because someone did give us a 1.
They did at the beginning, I remember that.
So since we last spoke, I did a triathlon. I've never done one before. That was good fun. Well, I say it was good fun. It was a scary swim, Steve. You like your swimming. This was pretty horrendous. But I think perhaps most importantly, I went on my first ever night out with Jamie last week. I don't think we've actually been out. We had a couple of pints together, but never a night out.
We went to the theatre, didn't we?
We did, and it wasn't very sophisticated because, and it's relevant to today, we went to see a live recording of the Socially Distanced Sports Bar, which is another podcast, but it's relevant because it was a podcast that was set up during lockdown where 3 blokes sit together, talk rubbish and discuss mutual topics of interest. In their case, sport. In our case, medicines. And if that sounds familiar, well, when we were planning the podcast, that was one of the sources of inspiration that we used. Unfortunately, they've gone on to make thousands in Patreon money and appearing live at the new theatre.
One of them's been very successful, hasn't it? Yeah.
Doesn't it go on for hours, though? Don't their podcasts go on for hours, I heard?
And hours and hours.
Yeah. How long were you there for?
2 hours in the theatre.
Yeah.
And then we went to the Rummer, the Bluebell, the old arcade, a dodgy club on St Mary Street, and Dots for chips.
Oh, okay. Well, it sounds like a good night. You did invite me, but obviously it's too far for me on a school night. I've got a couple of quick, funny things, actually. You know how much I love names of drugs and the way that people pronounce them.
Oh, you
So
do.
I've got a new technician working in the PCN this week, last couple of weeks.
You mean a pharmacy technician?
I mean a pharmacy technician, thank you. Yes, Sam would tell me off, and rightly so. So she was looking at a prescription for somebody who's got gout, and they wanted their colchicine, and I said something about it, and she said, "You mean cold chicken, don't you?" I was like, "What?" And if you look at it written down, apparently she had a patient that they used to call it cold chicken, or cold chicken, if you're in Liverpool. So I thought that was funny. And the other thing is that last week I had to drop something off. My nephew, who's also a pharmacist, was on the train from Poole to London. And I said, I'll give you something to take back to my sister. So I went to a station en route, if you like, where literally the doors open. I had it in a carrier bag. I handed it over to him. And a bloke who was about to get on the train said to me, "Have we just witnessed a drug deal?" And I said, "Funny you should say that, but we are both drug dealers, so yes, you have."
And what was in the bag? Cold chicken.
No, it was something for a birthday present for my brother-in-law.
Oh, you're not giving me much to work with here, Steve. Gee.
I don't think the socially distanced sports bar's got anything to worry about.
Look, it was the Press Script Awards yesterday, and so I just want to give a shout out to the 5 winners. Look, Hannah Said and the team at East Sussex for their work on delegation of insulin prescribing. Well done to them. David Ladenheim at Hearts Valley CCG for his antimicrobial stewardship app. Lisa Rogan and Anne Bentley from North East Lancashire CCG for their opioid reduction pathway. Jane Shanahan and Anne Bentley again from NHS Lancashire CCG for their work on anticholinergic burden scores and triage in care homes. And finally, Tracy Brown from NHS Glasgow and Clyde for her pharmacist-led chronic pain clinic. And so I think STC was in the audience yesterday. Some powerful stuff presented, yeah?
It certainly was, yeah. I think, might have some future guests out of that lot, actually. And Jamie, you shamelessly got in about the Oral Apothecary, so well done.
Reciprocity, I'm just giving back to Press Script now. But when you hear quotes from people in chronic pain clinic, thank you for giving our mum back. And before Tracy came into my life, I was giving up and had no hope. Tracely actually saved me that day. You can see the impact that these clinicians up and down the country and the medicines optimization teams are having on people. So it was great.
Reminded me of the Karen Sankey episode.
Yes, very much so. Okay, let's move on. It's my great pleasure to welcome Dr. Sally Lewis to the Oral Apothecary Podcast. Sally is, as I said, the National Clinical Lead for Value-Based and Prudent Healthcare. She's a practicing GP and an honorary professor at Swansea School of Medicine. You can read Sally's full bio in the show notes. Welcome to the podcast, Sally.
Hello, Jamie. Hello, everyone.
Hello.
Hi.
Thanks for coming on. What's I'm scared to ask this, Sally. What's on your agenda at the moment?
Oh, well, value-based healthcare as usual. So, as you know, we're coming out of a pandemic, I think, aren't we?
Are we?
Yeah, I heard we were. And the whole system is really struggling, isn't it? I'm a GP, as you know, and my GP colleagues are really struggling. ED are really struggling, and there are lots of people waiting for their treatment on waiting lists, so the whole system is creaking. I suppose that puts an even greater onus on us to make sure that everything that we do, every resource that we consume in healthcare, is contributing to a better outcome for patients, and then we're trying to do that as equitably as possible for COVID and non-COVID harm. So how do we use outcome data to prioritise our resources so that we do the best we can and try and improve the health of as many people as we can? And so there's a real renewed interest in value-based healthcare, I would say, and in digital health, which underpins it.
Some people listening might not recognise the term value-based healthcare. I suppose we're interested in it and how it applies to prescribing. Is there a sort of an elevator pitch or a brief descriptor that says what it is?
Yeah, so it's been described by a number of people around the world. There's Michael Porter and Elizabeth Teisberg from Harvard Business School who describe it as, you know, the outcomes that matter to people related to the costs of delivery of healthcare. And then we've got our own Professor Samir Gray in the UK, who is much more concerned about equity and about how we allocate resources to get better outcomes. And so I think increasingly what I'm seeing in the UK, in Wales obviously where I am, and across Europe, is a bit of a mashup of those two theories. So we are looking at improving the outcomes that matter to people. So that's not just clinical outcomes, that's functional outcomes and the goals and preferences that people have with the resources that we have, but also equitably. So somehow we have to balance individual wants and needs with population outcomes as well, and clearly that's a really tricky thing to do, and we have to try and find the sweet spot in the middle. So how does that relate to medicines, and how do we get the value out of medicines? As you know, I've been working in medicines for a long time as well, and we need to optimise medicines, we need to prescribe prudently, so we need to avoid over prescribing but also under prescribing. So that very much relates to value from the medicines that we're prescribing. We need to avoid polypharmacy and the harms of that, because obviously that will impact on outcomes for patients. But equally, I think it also means, what else do we need to support? What other activity do we need to support in healthcare to make sure that we get the best out of our medicines? So how much are we investing, not just in the drugs themselves, but in supported self-management for patients, in non-pharmacological interventions? I think you just mentioned something about chronic pain. You know, what else do people need alongside their drugs to fully optimise their outcomes? And that's something that I'm really interested in, what measures we put alongside medicines to get the most value out of them.
Yeah, so I mean, that was what I like about it really. I think the good thing about the outcome-focused approach, and we've touched on it before, is it knits the whole pathway together, so everyone's got a stake in the outcome as opposed to your particular silo part of the pathway. I think when we've looked at targets and outcomes related around medicines, it's specific to that medicine as opposed to the whole pathway of care. Sorry, Steve, you were coming in then.
I was just going to say, so I had heard the term via Jamie, but with not working in Wales, so I took the time when I knew that you were coming on to have a look at it. And I was very impressed by, there are 4 objectives, aren't there, right at the very beginning. And like all objectives and mission statements, they take a long time to come together. But the one I liked most was do what's needed, no more or less, and cause no harm. harm. And you probably may have heard us on the podcast, and in particular me, having worked in medical admissions for a long time. That's one of the things that I took a long time ago, actually, it was actually the very first National Service Framework for Cardiology in England. And the foreword, and I quote this a lot, and it was actually the Minister for Health at the time, and he said, we need to look for excellence. We need to do the simple things right every time. And the conversations that I'm having a lot recently is that everybody, perhaps both patients and clinicians, are looking for perfection. And actually, I think we have to lower the bar and we have to look for excellence. What do you think?
Yeah, I totally agree with that, Steve. And I think that one of the problems of evidence-based medicine is that it has protocolized a lot of medicine, and of course that has an upside to it, doesn't it, because it raises the bar in terms of standards of care and encourages us to practice evidence-based medicine. But the original definition of evidence-based medicine was that it had to take into account the preferences and goals of individual patients, as you know. So it's not just about following a protocol or a guideline. It's about using that to guide your practice in conversation and in partnership with your patients. And that's the only way to do just what is necessary, as the Prudent healthcare philosophy described. One of our colleagues over in Canada, Jessica Otter, is famous for saying that we should practice Goldilocks care. So it's care that is just right. And I love that. I think that's a really nice phrase.
So there's Goldilocks care, and I saw martini medicine today as well. I was...
What, anytime, any place, anywhere?
Yes.
That's one for the kids.
Yeah. Sally, I've seen you sort of describe this, but it does capture it for people, and I know it's work that's a little bit dated now, but just briefly do the work with the inhalers of where that work that you did those years ago on the inhalers and pulmonary rehab, etc.
Sure. So to re-emphasise a point that Paul just made, to look at value, you cannot do this in isolation. You have to do it across a whole pathway of care. So for a chronic condition like COPD, like chronic obstructive pulmonary disease, that means looking at prevention. It means looking at timely, accurate diagnosis. It means optimising intervention, including drugs, and supportive therapy, and also on into very good palliative and end-of-life care too. So you can't miss anything out. And one of the problems that we constantly see, I think, in healthcare is an inability or a difficulty to invest in supporting patients' needs, particularly around what might be perceived to be the softer stuff, like supported self-management, so in COPD, breathe easy groups, approaches to pulmonary rehabilitation, and so on. So how do we get investment in these kind of really good non-pharmacological interventions, which may be all too easily neglected, but are absolutely essential for getting the best outcomes for patients and for getting the value out of the medicines? We did test in South East Wales a number of years ago now, a way of rebalancing resources across a pathway for highest value. So if you look at what is of highest value in terms of interventions in COPD, and I'm talking value now in terms of cost per quality adjusted life year, so quite a sort of health economist's purest view of value. The cost per quality for an inhaler is really high compared to the cost per quality of smoking cessation or pulmonary rehabilitation, for example, which is cheap as chips, but clearly if you can prevent COPD, that's the highest value intervention of all. But we need to support people for better outcomes. So if you are spending gazillions on triple therapy, in inhaled therapy and COPD, and totally neglecting pulmonary rehab and other supported self-management interventions, then you are not getting highest value for your patients in that pathway. So we looked at our data, and data really does underpin a lot of what we do in value. You have to know what's going on, and we looked at our outcomes such as we had then, which was fairly limited outcome data at the time, around hospital admissions, lengths of stay and that kind of thing, and the QOF data from general practice. And we looked at our spend on inhalers in COPD, and at that time we were by a country mile the highest spend in COPD inhalers of anywhere in the UK, I believe, which was quite spectacular. So we formed a multidisciplinary group, including patients, pharmacists, primary and secondary care. Crucially, finance were in the room. I'll mention that right away. And we came up with a plan to optimise inhaled therapy with using a patient-led approach, a device choice-led approach. And we realised that we could save a considerable amount of money in doing that. But the deal was that we would reinvest a portion of those recurring savings into the gaps in the pathway. So a little bit of that was directed at new services in pharmacy for level 3 smoking cessation, also into pulmonary rehabilitation where there was inequity of access in the health board at the time. And that was a really successful project. It took about 2 years, but really did have an impact. I'm not going to say it's easy, but I think it's a technique which is replicable in other areas as well.
It was so impressive when I read that in the report. That's the only time I've ever heard any